Hello and welcome everyone to our Urology Group presentation of BPH, and we'll go ahead and get started here. So I'm Ryan Flynn. I'm one of our docs who works over on the west side of town. I also see patients in Norwood. BPH is one of my most common topics to discuss with patients, and amongst other things that we do, treating stones and cancers. So we'll talk about the BPH stuff tonight. So what is BPH? Stands for benign prostatic hyperplasia. It's often referred to as an enlarged prostate or benign enlarged prostate. So benign meaning non-cancerous. This is a very treatable condition, and it's a very, very common condition. Again, one of the most common things that I can that I see in my office. Over 50% of guys who are 50 years old have BPH as a problem, and up to 90% of people over 80. So patients come in often asking, why did they get this? And most of the time the answer is you just lived long enough. We don't really know why guys get BPH. We think it has some change in the sex hormones as people age, typically around that age 50. But again, it's a very, very common problem. So how does it affect your bladder? There's two ways that I really think about this. It's the prostate itself and then how it affects the bladder. As the prostate gets bigger, it pinches off this urethra, the channel that runs right through the middle of the prostate, which is the outlet point of the bladder. That can cause a first set of symptoms, which are the emptying symptoms, trouble with slowing down of your stream, stopping and starting. And then it secondarily causes problems with the bladder by pushing back on the muscle wall and making that muscle work harder to compensate and push through the obstruction. So that causes a second set of symptoms called the storage symptoms, which are the urgency and the frequency and the getting up at night. There's ways that we check your symptoms when you come into the office. We have a score sheet that we give most people to try and figure this out. And these are some of the things that you guys are probably here to listen to because you may be having these symptoms. Most common symptoms, again, I kind of separate these into two categories. There's the storage symptoms and the emptying symptoms. The storage symptoms are the urgency, the frequency, the getting up at night, and the ability to empty your bladder, slowing down in the stream, stopping and starting. And sometimes they'll combine to have issues with the actually leaking urine. Sometimes it gets beyond just the quality of life side effects from benign enlargement of the prostate and actually can start to affect your health in more ways, causing urinary tract infections, typically from the bladder not emptying all the way. Bladder stones, which develop in a different way than kidney stones. They, again, develop from the bladder not emptying all the way and that urine concentrating within the bladder, and that can cause problems with bleeding or, again, lead to infections. If it gets really bad, it can lead to kidney failure by backing up pressure all the way up to your kidneys. And at some point, sometimes it can even get bad enough to damage your bladder so much that the bladder doesn't squeeze and empty all the way, and you have to use a catheter. So we're here to try and help prevent that from happening and treat this before it becomes too late and doesn't have as many options for you. Again, BPH does not increase your cancer risk. It's a problem in the same organ as far as prostate cancer goes, but they're two completely different entities. So how do we look at BPH? How do we diagnose it? Again, the first part is taking a good history, talking to people, going through that symptom score. We have that sheet that we have you fill out at the beginning that gives us an objective measurement of how bad are the symptoms and what kind of range are you in and what type of options we have. And then there's, of course, physical exam. Everybody's favorite test, sticking a finger up into your bottom to feel the size of the prostate. It gives us a rough overview of the size of the prostate, as I mentioned, and is also looking for lumps or bumps that are more concerning for a cancer within the prostate. There's also a PSA blood test, which helps us to determine cancer risk. That's a routine screening test for guys as we get about over age 50. There's urine tests that we, again, typically do when you come into the office, and very commonly we'll also scan your bladder after you pee in order to see how much urine you're holding on to. And when it comes to the point that you're not emptying all the way, that can be a pretty clear indicator that there's trouble along the way and it may be time to intervene. There's more tests as far as your bladder function goes. So again, the bladder and the prostate have to work together in order to empty your bladder correctly. The prostate channel has to be open wide enough. The bladder has to be able to generate enough pressure in order to get through that obstruction if there is an obstruction. So there's a couple of tests that we can do. One is relatively simple in the office. It's called a urocuff. Again, simple and quick, done in the office while you're awake. A small cuff goes around the penis to measure how well your bladder is emptying. And then there's a urodynamics test, which is a little more invasive testing, a little longer process to do, but gives us a lot more detailed information if we're really not sure where the symptoms are coming from. Then there's more tests beyond that. What's called a cystoscopy, which is analogous to a colonoscopy, taking a scope and looking into your bladder, though, and not into the rectum or the colon. And this is inserting a small camera to look at the size and the shape of your prostate, tell us how much it's blocking, and again, what's the overall shape that should be able to maybe causing that obstruction. There's different anatomic variants in the way that a prostate can grow, and some of them are better treated one way rather than others better treated in different way. It also looks for anything else that could be the source of the urinary symptoms and be a confounding variable. If there's stricture or scar tissue along the way in the urethra, are there any tumors in the bladder or stones within the bladder that are causing trouble? So it's a good anatomic test to help tell us what's going on. We'll often combine that with an ultrasound. It's called a transrectal ultrasound. It's the same way we do a prostate biopsy by using an ultrasound probe into the rectum, but we'll often use it without actually doing the biopsy in order to just check the size of the prostate, and it gives us the most accurate volume measurement. Again, this is done to help tell us, do you have a relatively small prostate that you need a less invasive option, or is your prostate really big that the least invasive option is not going to be the best option for you? Sometimes we do go ahead and do a biopsy as well if your PSA or your rectal exam tells us that there's something that's higher risk there. There's a whole bunch of treatment options when it does come to BPH, though, which is a good thing and a bad thing. One, we've got options. Two, there's not one size fits all treatment plan for everybody. So that's why it's important to come in and talk and have some tests done in order to figure out which option is going to be the best for you. Usually, as most things in medicine, we start with the least costly and least invasive treatments first. Lifestyle changes, avoiding certain medications before we're adding medications. And then we start to talk about adding medications, procedures, and the options, again, start with lifestyle changes. How well are you emptying your bladder? Are you taking the time to relax and get your bladder emptying? How much fluids are you taking in? Again, it's not always prostate related. Sometimes people will come in and say, yeah, I have to pee all the time, but they're drinking a 2-liter of Coke every day, and it's just a matter of volume intake that is making their volume output go higher. The other things that are very common complicating factors, how much caffeine and alcohol are you drinking? That can really affect how much urine you're producing and how much your bladder is irritated, and therefore how frequently you're having to go. So again, those are the things we're trying to parse out and figure out who's having the problem for what reason. Is it all prostate? Is it bladder? Is it a combination? More often than not, it's multifactorial. It's a combination of the things that are adding up to problems. There are certain medications, as I said, that can worsen your symptoms. Antihistamines can slow your bladder down. Decongestants like Sudafed or actually alpha agonists can tighten or constrict your bladder neck and your prostate, which can make things worse. Again, things like Valium and narcotics can slow down how well your bladder is actually squeezing and emptying. The last point on here, there's a lot of over-the-counter medicines that are out there, and people love to try and use supplements, and if they work for you, great. But I caution everybody who comes in my office about using the supplements is that they're just not regulated the same way that the rest of these medications are, and so we just don't have as much evidence to base how well they're going to work and how safe they are for patients. If they're working for you, great. If you're spending a whole lot of money on them and they're not doing the trick, I would probably caution you to save your money. There are a few medications that we use, have been around for a long time, and typically are used to treat mild to moderate BPH. Alpha blockers are the most common. Far and away, the most common of these is Flomax, or tamsulosin is the generic name for it. Been around for a very long time. A very safe and effective medication overall. What it does is it helps to relax the smooth muscle of the prostate and the bladder neck to open up that channel. And I always think about it as widening out that funnel to make it an easier passage for you to pee through. As that happens, the bladder gets to relax. It gets to work more easily and efficiently and really empty better. If you're emptying better, it doesn't mean you're peeing more. It means you're peeing more efficiently. And so again, your bladder can relax and calm down. And oftentimes that helps to decrease the urgency and the frequency that you have as well. 5-alpha reductase inhibitors are another group of medicine. They actually shrink the size of the prostate. They work best on guys who have really big prostates. But there's, with both of these sets of medicines, there are risks and side effects that come along with even just taking the medicines. Sometimes they're very well tolerated and an important part of treatment. But there's, as with anything, as with doing nothing or doing surgery, just with the same with medications, there's risks to doing that as well. That again have to be taken into account when you're putting the whole puzzle together. So if you've tried the lifestyle changes and they're not working, if we try a medication and they're not working, or you're not liking the side effects, there's multiple treatment options that are available. And this is honestly the sweet spot of the urologist, is beyond the initial steps. If they haven't gotten you there, what more can we do to really improve the quality of life and keep you safe and keep your bladder healthy in the long term? The first one that I have to talk about tonight is a UroLift. It's a minimally invasive procedure that lifts the prostate tissue out of the way. I do think of it as window curtain tiebacks. We're really, rather than cutting out and removing the tissue, we're pushing that tissue off to the side again to create a nice wider channel in order to pee through and get rid of that excess prostate tissue that's in the way. You're not actually removing it, but you're pushing it off to the side because it tends to be soft, spongy tissue that's very mobile. As you do that, if you can pee better and more efficiently, it again will decrease those symptoms. Things I like about the UroLift, it's an outpatient procedure, meaning you come in, you go home the same day. It's a relatively lighter sedation for most patients. And about 80-90% of the time, you don't need a catheter in after the procedure, which is different than a lot of the more invasive procedures. Again, being the least invasive of these options, it's not the right one for everybody. If you've got a really big prostate, you've been having symptoms for a really long time, and the bladder's a little weaker, or again, there's size requirements that it has to be below in order to really qualify for a UroLift. But that's the kind of stuff that we check out, and the reasons that we do the tests that we do, like the scope, like the ultrasound, in order to see if you're a good candidate for it. Again, the thing about the UroLift that I like the most is its relatively low side effect profile. There's no erectile dysfunction risk. There's no ejaculatory dysfunction risk. We tell you to take it easy for about a week, but with some of the more invasive ways, we talk about 2 to even 4 or 6 weeks that you got to take it easier because of the increased bleeding risk. The biggest complaint that I have from patients who have a urolift done is the first 3 or 4 days can be a bit off-putting. The symptoms can often get worse: urgency, frequency, some painful urination in that time period. But again, it's a short-term pain for a long-term gain most of the time. So again, there's definitely benefits and there's certainly risks, but it's a matter of figuring out which procedure is right for the right patient, and that's again why we do that testing up front. A TURP, or a transurethral resection of the prostate, is still the gold standard. It's an oldie but a goodie, and this is a procedure that's been around for 100 years. It's effective, it's proven, again, as I said, the gold standard. And this is where we go in and actually cut out and remove tissue from the prostate in order to open up that channel and help get the voiding symptoms better. It's often done as an outpatient, although sometimes there's a lot of circumstances that may make us switch this to do it inpatient and stay overnight in the hospital. It's a little longer, deeper anesthesia, but not too long, usually about an hour or so. Everybody keeps a catheter in after this one, which can be a bit of a burden, but again, it's usually less than 12 to 24 hours. Sometimes it can be for a couple of days if we have more extensive tissue to remove. There are some more risks associated with this one, though. Again, sometimes a better effect because we're removing more tissue, but sometimes more risks that come along with that. About a 1% risk of erectile dysfunction and incontinence, a much higher risk of an ejaculatory dysfunction after this. And as I said before, you kind of got to take it easy for a good 2 to 4 weeks after this one because of the raw surface on the inside there that can increase in bleeding risk in a longer term. We do, again, remove tissue with this procedure, and so we send it off to the pathologist and check it for cancer. We're usually finding insignificant cancers when that procedure is done, because if there was a higher risk of cancer, that would have been figured out beforehand. Green light laser therapy is another one that I use. This is, again, using a laser to remove the tissue rather than scraping or cutting it out. It actually vaporizes it by the laser being attracted to the hemoglobin in the blood cells. This is best for small to medium prostates. It certainly can be used for larger prostates, but it's not, I wouldn't say it's as effective as really going in and cutting that tissue out. People that tends to be best for are guys who are on anticoagulation, which is, blood thinners that can make the bleeding risk higher. Although, again, it can be used in guys who just find it as a happy middle ground. Typically, again, catheter has to stay in. This can either be done as an outpatient, going home the same day, or depending on the situation, a one-night stay overnight in the hospital. Very similar risk profile to the TURP, the transurethral resection over the prostate. The biggest difference between it is the bleeding risk is a little bit less, and that can encourage us to do more of these as an outpatient. But again, it depends on the situation. If you're on a blood thinner or not, sometimes, and you can't come off of it, sometimes this is the only option in order to get the procedure done in a relatively shorter time frame. Aquablation is a relatively newer technique that we're pretty excited about the possibilities for. Again, in the right patient is the biggest thing as far as this goes. This is, I think of it as using a pressure washer, which doesn't sound like the nicest thing, but similar to what it is, it's using powerful heat-free water jet to remove that prostate tissue. It's done by a surgeon-assisted robotic technology, so we're in charge of it. And basically, we program the device to the contour of the prostate using an ultrasound and some very close monitoring and with our scope to figure out where exactly we need to go. Some of the benefits of this are that it can preserve your ejaculatory function while still working on very large prostates. So a normal prostate size, I didn't mention before, but normal is usually about 20 to 30 grams. kind of normal average big is maybe 40 to 60, and then we see some more that are over 100 or sometimes even 200. And so again, those can be big determinants of which of these options is going to be best for you. And so this is a nice option for guys who have bigger prostates but want to minimize their impact on erectile and orgasmic function. The HoLEP or HoLEP is holmium laser enucleation of the prostate. This is a really cool way to treat really big prostates as well. It's using a laser to core out the prostate in one piece, kind of from the inside out. The next slide on here has a good diagram of this. It's a relatively bigger procedure, and so does usually require a one-night overnight stay, and definitely is a general anesthesia. But here you can see on the diagram how we think about, rather than just cutting out the tissue from the inside, we're really getting out all the way to the rind of that prostate, if you will, and getting out the bulk of the tissue from the middle. And again, this is really great for guys who have really big prostates, who we know we got to get a lot of tissue out, because the least or less invasive ways of going about it are just not going to do the trick. A similar way to do it in a different way is a robotic or not robotic, open, simple prostatectomy, or suprapubic prostatectomy, different words that we use for this. This is, again, a surgery to remove the inside part of the prostate in a very similar way that the HoLEP does it, by getting out to the surgical capsule of the prostate, as we talk about. But we're actually going in and doing this robotically from incisions within the abdomen. One of the benefits of this versus the HoLEP is there's more people who are familiar with this technique. That the holmium laser way, there's really only one of our partners who is doing those significant portion of the time, whereas there's several of us who are doing the simple prostatectomies. Patients have a really good result with this. It's, again, a matter of finding the right patient and the right procedure for the right patient. There are a few more risks to the, a bigger procedure like this, but again, we talk about this option much more for patients who have bigger prostates and therefore need bigger procedures in order to get the desired result, to get being better. Sometimes it's to get rid of a catheter and really give you the best possibility of a good long-term durable result. With all of these options, again, there are going to be healing time that takes place. It may be 6 weeks until the urinary symptoms calm down. And it's very commonly 3 to 4 months after the procedure until you're really into a new baseline of improvement of especially those urgency, frequency, and bladder symptoms that come from the BPH treatments. That's all I've got for the slides for tonight. Now is a good time to put your question in the chat box if you've got some questions, and I'll start to scroll through and answer them as I can. There's a question about Vesicare as a medication for urgent urination. And yeah, I didn't really touch on that much, but absolutely. So again, there's two components here. There's a prostate component, and then there's a bladder component. And medications like Vesicare, which is an anticholinergic, or there's relatively newer ones like Myrbetriq that are is a beta-3 agonist. And they're medicines to help the bladder relax and, again, work on the urgency, frequency component. So very good medications as far as that goes. Sometimes, though, I worry that we're treating just the symptoms without getting to the root cause. And oftentimes the prostate is really the root cause of the problem. And sometimes in just treating that, we'll end up treating the bladder symptoms as well. We've got some good list of questions coming in here, so I'll keep working on it. I think these slides will be available And the whole presentation, not that you want to watch me again, but will be available to you guys after this finishes up. There's a great question about, does losing weight help? And the answer is absolutely yes. It doesn't help or have any change in as far as the prostate itself goes, but there's really good evidence to say that weight gain and obesity can contribute to overactive bladder symptoms. If you think about it, it makes sense. Just physics. You got more mass in your abdomen pushing down against your bladder, and that can cause a lot of issues of basically not being able to stretch as much as you'd want it to. And so there is good evidence to say that you can have decreased overactive bladder urgency frequency symptoms with losing weight. Does Medicare pay for the UroLift? Yes, most of the time it does. We always check that before a procedure goes through, but that has not been a problem recently. Tamsulosin, if you take that, is it a forever medicine? It can be. Basically, yeah, it's not like an antibiotic that we're going to treat you for a short time period and then it's better. There's a few instances that will give it a short trial, and sometimes it's just breaking the cycle. But most of the time, if you get started on a medicine like Tamsulosin, it's only going to work while it's in your system. So it doesn't really help for just taking it for a short time period. It's, again, one of the reasons that we'll sometimes talk more about doing a procedure in order to just fix the problem rather than say you're on this medication ad infinitum. Great question. Will BPH naturally cause a rise in PSA? And the answer is very commonly yes. PSA stands for prostate specific antigen. It's a blood test we use to screen for prostate cancer, but it's not cancer specific, it's just prostate specific. And so the BPH, as the prostate gets bigger, it very commonly produces more PSA. And so it's one of the things that we have to test at the beginning to figure out, is that rise in your PSA coming from a cancer risk, or is it just coming from the benign enlargement of the prostate? But a very common kind of gray zone that we have to figure out before we figure out which treatment options are going to be best for you. Ejaculatory dysfunction. The biggest way that these medications and treatments cause ejaculatory dysfunction, what that means is what we call retrograde ejaculation, which doesn't explain it any better until basically what happens if we open up that channel of the bladder neck. The semen will take the path of least resistance. Rather than coming out through the long urethra, it will often go back into the bladder, retrograde, and therefore be caught in there. And so you'll have lack of semen coming out, lack of ejaculate coming out as you're, typically you can have an orgasm, but oftentimes these procedures or even the medications can cause the ejaculatory function, which is the lack of, again, the semen actually coming out. What does the prostate do? It's a small organ that basically produces some of the fluid of your semen. So it's not vital for life at all. It's vital for reproduction. But once you're past your childbearing years is when the prostate tends to cause all the trouble. It gets larger and causes this BPH that we've been talking about, or it can grow a cancer in there. But again, the problem with it is that it's stuck way down deep in the pelvis. It's not like you can just take it out without any risks of side effects, as we discussed going on here. How long do these procedures have lasting effects? Great question. I forgot to mention that the average, I always describe it as a life expectancy of any of these procedures is 8 to 10 years. But you can imagine that the less invasive procedure, something like a UroLift, is probably toward the beginning of that curve, maybe in the 6 to 8 year time frame, that the average benefit is going to be. And TURP is, in that sweet spot of 8 to 10 years, or the more invasive procedures may be better even longer. But that's an average. So you may have patients with any of the procedures who are having more symptoms come back in 2 to 3 years or 5 years. Or you will have the opposite end of the spectrum, that you have guys who are 15 years out and still doing great. So there's several, possibilities for that, and it's a bell-shaped curve, as most things do. But the general consensus, what we expect and hope for, is about 8 to 10 years. Again, we're always just trying to find the happy balance. We don't want to be too overly aggressive in doing the procedure, hoping for a result that lasts longer, but then also increase the risk profile in the same time frame. Why is urination more difficult at night? That's a great question that I get all the time, and I wish I had a better answer. The best way I describe it, though, is again, thinking about the functions of the bladder. It's supposed to do two things. It's supposed to store and it's supposed to empty. And most of the time at night, it is focused on the storage side of it. And so when you wake up in the middle of the night, sometimes your bladder just doesn't wake up with you, and it will just not go into that squeezing mode as quickly as we want it to. I often hear guys describe that they get up and walk around a little bit more, and it wakes things up, and then you get going a little bit more. But far and away, the most common complaint is first thing in the morning or through the night, that the stream is slower and weaker. Opinion on saw palmetto. Most common supplement that's out there for prostate disease, whether it's BPH especially, or even prostate cancer. There's really good evidence to say that it's not harmful, and pretty good evidence to say that it's not much better than a placebo. Again, this is where I'll tell guys, if you're taking it, it's working for you, great, have at it. There's probably things that we haven't been able to parse out in these big population studies to be able to say who exactly it's working for and why. But again, if it's not working for you, I wouldn't just stick at it, because you probably do need something more. Does UroLift implant affect ability for prostate MRIs? The answer is no. You can do them afterwards, whether we're looking for a cancer or any other reason. There's a few caveats to the MRIs and certain techniques and ways of doing MRIs. But again, I've had many patients have prostate MRIs after UroLift. It could affect it in a way of reading it, and is it going to distort the image at all? It's possible, but it doesn't affect your ability to actually do that. Which local doctors are performing aquablation? Really, the only one in our group is Dr. Aaron Bay. He works out of the East Side office, and he's been our foreman on that project. So again, that's Aaron Bay, B-E-Y. Any age limits for the procedures? Nope. We've treated people in their 40s up to people in their 90s. I don't know if we've gone over 100, but that wouldn't be a limit. It really depends on how the symptoms are and the relative health of the patient overall. It's common for Flomax to cause dribbling after you stop urination. Not common. Usually actually helps to stop with that by helping to empty the bladder better, but again, there's a lot of variability there. Stents in the treatment of BPH. It's been tried in the past. It did not go well. Would not recommend it. We got quite a few more questions here, so I'm gonna keep trying to get through some more of these, but if we don't get to them all, that's when we'll certainly encourage you to go and talk to your doc and talk more specifically about your scenario. Of all these procedures, which is the longest lasting or permanent? Certainly those last couple that I talked about, the whole leap or a simple prostatectomy, are ones that we really think we're getting the majority of the adenoma, the bulk of the prostate, benign BPH tissue out. And so those are the ones that we think are going to last the longest. But again, they come with more significant risk side effect profile. Total removal of the prostate, how often is this recommended? Again, We only really do that for cancer reasons of the prostate, and that's because the risk profile that goes along with that is much more significant than any of the risks that we're talking about as far as these BPH procedures. Following these procedures to reduce prostate size, is there any probability the prostate will enlarge again? Absolutely, there is. I mean, again, some of the more invasive ways we're really getting that tissue out, and so it's either just not going to enlarge enough, or sometimes we actually are removing all of that growing tissue. But some of the less invasive ways, that tissue is still in there and certainly can grow back. But again, it's a matter of finding the right balance of the risks and the benefits of the procedure for the individual patient. That, okay, I'll take the probability that this is going to cause trouble 5, 10, 15 years down the line for not having those quality of life side effects that can happen depending on which procedure you choose. Floppy iris syndrome and tamsulosin, that's an interesting question. Very common phenomenon that basically is important for ophthalmologists as they're doing eye procedures, particularly cataract surgery. Flomax is so common now that they basically all use a technique that they have to adjust, that they have to use, because we even give it to people who have stones who weren't treated, and the floppy iris syndrome can happen after just a single pill of Flomax. So they have basically had to adjust their technique in order to discount the risk that comes from that associated with the Flomax. Question about using Viagra or Viagra type products after procedures like this. Again, that is widely variable. None of these procedures are directed at helping erections or hurting erections. Again, there is a very mild risk to erectile dysfunction after almost any of these procedures, pretty much other than the UroLift. Usually, again, around 1 to 2%. So the risk of the procedure is pretty minimal on the ED, but it doesn't really change the outcomes of what options there are for either before or after treatment in terms of treating ED. If you take blood thinners, does it mean laser treatment is better than the UroLift? Maybe, maybe not. Again, if you can come off the blood thinners for a week or two, very safe to be able to do a UroLift or even a TURP and not necessarily need the laser. If you can't come off of it at all, again, I'm a little more gray ground. Couple more questions about Proscar or finasteride. Again, there's a lot of good evidence to say that, and it's been around a long time to show that it is effective for helping to shrink the prostate and help with these urinary symptoms. In my practice, it's a matter of, again, weighing the risks and the benefits of them, and sometimes we end up transitioning to let's fix this rather than just keep treating the same problem further and further down the line that is not really getting to the root cause. Foods that you can eat to reduce prostate size, no. Recent study came out saying plant-based diet is better to decrease prostate cancer risk, but otherwise there was another good study just a few years ago that, for better or worse, says what you're eating and drinking doesn't affect the size of prostate and the growth rate as much as we'd like to be able to do. There are even more prostate cancer treatments than what we've discussed tonight. Prostate cancer as well as BPH treatments than what we've discussed tonight. Again, more than one way to skin this cat, and it's a matter of figuring out which one's right for you. I think that hopefully I've covered the majority of this for you tonight. I do want to mention as we're wrapping up tonight that we have a 50th anniversary tribute to our Vietnam veterans. This is a free public event. It's as you can see there on Wednesday, March 29th. It's at the Cintas Center on Xavier University's campus. You can get all the information at the website, which is honorvetsevent.org. I went to one of these a few years ago, and they do a really good job of honoring. This is to honor all vets. It's in part to do it for the we're holding on the 50th anniversary of the final troops coming home from Vietnam, since some of them did not get the welcome home that our veterans we think they should. This is again to honor all vets, not just Vietnam vets, and a free event that's open to a public. So really encourage you to check it out, and if you're interested, go ahead and register for that event as well. Thanks for your time. Hopefully I've helped answer some of the questions. If not, certainly we would recommend you follow up with your urologist and make an appointment to see one of us so we can help to tailor the treatment to fit what you need. Take care. Good night.